Now we have seen paraneoplastic syndrome. Let's move on to diagnosing other tumors. So how do you diagnose? So firstly, we can do a cytology. So cytology can be either of exfoliative cytology or a fine needle aspiration cytology. So exfoliative cytology is nothing but the cells are going to be shed. So the shed cells are going to be collected and then we are making a smear out of it and seeing the morphology of the cells. So exfoliative cytology, the examples will be bronchial washings. So we can detect any pleural or a lung malignancy. And then pap smear. So pap smear is the best screening test we use for detecting cervical cancer. So it's a screening test. So this pap smear is going to use the Papanicolaou stain, and this Papanicolaou stain you'll have to use the fixative, which is 95% ethanol. So immediately after making the smear from the IR spatula, you will have to spray it with this 95% ethanol before it gets dried. Then under fine needle aspiration cytology, it is nothing but you are going to use a single syringe or directly you can use a needle also. So directly you are going to, if there is a swelling, you are going to put the needle in there and do it like this, so that due to capillary action or due to aspiration, the cells from the swelling is going to enter into the hub of the needle. So and then you are going to use the material and spread it on a glass slide, making it a smear. So you can use multiple stains to stain this smear. Usually we use Giemsa stain or Diffquick stain. For this we are going to use a air dried smear. Okay. For pap smear you are not supposed to air dry it. For Giemsa you are supposed to air dry it and then put a Giemsa stain on it. Okay. So the one of the disadvantages of using FNAC is thyroid. Usually for thyroid neoplasms we do a FNAC first, but in thyroid neoplasms this FNAC cannot differentiate between a follicular adenoma and a follicular carcinoma, because follicular thyroid carcinoma you can only diagnose when you see a capsular or a vascular invasion, and it is impossible to detect a capsular or a vascular invasion on FNAC. So both the follicular adenoma and follicular thyroid carcinoma are going to resemble the same in FNAC. And as such, FNAC is going to be contraindicated in testicular tumors because testis is supposed to be a immune privileged site, right? So when you put the needle, the tumor cells can use the needle track to spread. Okay, so it can come out and it can spread. So it is contraindicated in testicular tumors. Then there is something called as a Franzen's handle. It will look like a gun. So this Franzen's handle is used for FNAC. So after cytology, you can go for a biopsy. So a biopsy can be taken from the tumor and then you can use it for, you can test that. So you can use a light microscopy first. So for light microscopy, you have to fix the tissue in 10% neutral buffered formalin. So 10% neutral buffered formalin. So this is the fixator which we use in normally for histopathological examination. So once you put it in that, then you process the tissue and stain it with HND stain, which is hematoxylin and eosin. So after that, you can see the slide. And you can also use electron microscopy. For electron microscopy, the fixative is 2.5% glutaraldehyde. So the fixatives they can ask. For pap stain, it is 95% ethanol. Then for light microscopy, it is 10% neutral buffered formalin. For electron microscopy, it is going to be 2.5% glutaraldehyde. Okay. So after that, you can also use immunohistochemistry to identify the origin of the tumor. So on light microscopy, you are seeing the tumor, so HND stain. And then after that, to tell whether the origin of the tumor is an epithelial tumor or lymphoma or it is a mesenchymal tumor or any specific origin of the tumor, you can use this specific markers in for diagnosing the origin of the tumor. So that is called as immunohistochemistry. So as the name suggests, it is going to be immuno. That is, there is going to be some kind of antigen antibody reaction. So the antigen is going to be present in the tumor. So you are using some markers which are basically antibodies against this antigens. So a reaction is going to be taking place between this antigen and antibody, and that is this antigen antibody reaction. We are going to highlight it with the help of a dye. So we use DAPI stain usually. So this DAB stain usually. So DAB is diaminobenzidine. So that is going to impart a brown color to the tumor. So wherever this brown color is coming, it is going to highlight wherever that antigen of the tumor is going to be present. So let's see examples. Here again, this is an important table for MCQ. So to prove that it is a carcinoma, you have to use cytokeratin. So cytokeratin is actually an intermediate filament expressed by the epithelial cells. So carcinoma is an epithelial malignancy. So cytokeratin is the marker for carcinoma. Similarly, vimentin, again a intermediate filament which is expressed by mesenchymal cells, is the marker for sarcoma. Then lymphomas, we can use CD45. So CD45 was nothing but leukocyte common antigen, LCA, right? So any lymphoma is going to express this CD45. Then Hodgkin's lymphoma, the classical Hodgkin's, we are going to have CD15, CD30 and PAX5 positivity. Okay, and LCA is going to be negative in this. Okay, LCA is going to be negative in Hodgkin's, classical Hodgkin's lymphoma. Then LCH is Langerhans cell histiocytosis. Here, the marker we use is CD1A. Then we use CD207, which is also called as Langerhans. CD207 is Langerhans, and we can also use S100. Okay, for malignant melanoma, we have to use HMB45, Melan A, and also S100 again. S100 is kind of a non-specific marker. We can get it in multiple tumors. So just remember CD1A and CD207 for LCH, and malignant melanoma HMB45 and Melan A. Ewing sarcoma, it is CD99 and Fly1. Osteosarcoma, osteopontin is the marker. Dysgerminoma or seminoma, which is a germ cell tumor, we are going to use PLAP, OCT3x4, NANOG, and also LDH. Yolk sac tumor, we can use alpha feta protein. Granulosa cell tumor, it is a X-cord stromal tumor, we can use inhibin. Then neuroendocrine tumors, anywhere in the body, we can use synaptophysin, chromogranin, neuron specific enolase NSE, bombesin. So these are the markers for neuroendocrine tumors. So these are these four are usually present in the neurosecretory granules in the neuroendocrine tumors. So immunohistochemistry is done. We can use flow cytometry also. So flow cytometry, as the name suggests, flow is something is flowing. Cyto means cell and metry is measurement. So we are going to pass the cells in a funnel kind of thing here, and the cells are going to pass in a single file like this. So one by one the cell is going to pass, and then when the cell is coming out, you are going to pass a laser right. So the cell is going to be attacked by this laser right, and this cell is going to cause the laser light to be scattered. Either the light can be scattered forward or light can be scattered sideways. So forward scatter denotes is the cell size. So based on the cell size, the amount of forward scatter is detected. Then the side scatter is going to determine the cell's content inside, basically the density of the cell. So the cell's granularity. So some contents of the cell are going to determine the side scatter. So especially this flow cytometry is used for detecting leukemias and lymphomas. So there you can use the various CD markers also, and also based on this side scatter and forward scatter, we can determine the size of the cell and the granularity of the cell. Okay. Then we are going to circulating tumor cells. So this is a newer concept basically. The circulating tumor cells and cell-free DNA. CTC circulating tumor cells and cfDNA cell-free DNA. So from the tumor mass, some kind of certain circulating tumor cells will be there, which are trying to undergo metastasis basically. So and the DNA from the tumor cells can also be released. So these two are going to be circulating in the blood. So rather than going and taking a biopsy, you can take the blood sample directly and study these tumor cells, circulating tumor cells and the DNA. Okay. So biopsy, you need to put the patient under OT and then give them anesthesia and take the biopsy, right? But instead, you can just take a blood sample like you are drawing a venipuncture, and then you can study these circulating tumor cells in the blood. So it is quite tedious actually to retrieve a live viable kind of circulating tumor cells. But if they achieve it, it is very, very easy because it's quite less cumbersome, right? And you can study the mutations and the prognostic factors, everything from that cell itself. So this is an upcoming field actually. And the circulating tumor cells can be studied mainly in melanomas and carcinomas. Any tumor basically. And then we have molecular methods. So molecular methods, we have PCR and all those things which we discussed again in genetics, right? So the same methods can be used. So these molecular methods are very important nowadays, because most of the classifications of the tumors under WHO has been based on molecular. So slowly we are going into the molecular era. So morphology is definitely there, nothing can replace morphology, but molecular is taking over. Okay. So with the help of molecular methods, we can detect you can use it for diagnosis, like in the case of CML. So CML, you can diagnose only when you see the translocation 922. So it is diagnostic in that sense. You can use FISH to detect this translocation. Then prognostic significance. So for neuroblastoma, if you see, I mentioned NMIC amplification is a poor prognostic factor, both for neuroblastoma and medulloblastoma, right? So NMIC amplification you can check for and tell that it is having a poor prognosis. Then minimal residual disease, so MRD. So for acute leukemia, post treatment you have to check whether it has responded or not, and whether there is any tumor cells left in the body. So for that you will have to check it with the molecular methods only, because a very small kind of tumor cells in very less powers will be there. So with that, only with the help of molecular methods you can identify the minimal residual disease. Then you can check for susceptibility of cancer. So if there is a risk of cancer in a family, so they are having multiple cancers. So suppose a HBOC, hereditary breast ovarian cancer. So the family, they are having some prostate cancer, colonic cancer, or breast cancer, ovarian cancer, and someone in the family needs to test for this. So for that you can use this molecular methods for testing. So BRCA1 or 2 you can test for breast cancer, HBOC. Then for identifying targeted therapies, the most important implication nowadays is this targeted therapy, meaning for APML, if you see, there is this translocation 1517, which is characteristic for APML, like CML 922, 1517 is characteristic for APML. So there is going to be fusion of PML RARA. So this PML RARA is the fusion, and if this fusion is detected, you can give a therapy called as ATRA, retinoic acid basically, ATRA and arsenic trioxide. So ATRA and arsenic trioxide, if you give to these patients, it is curable. So APML is curable if you give this treatment. Okay. So targeted therapy for that particular molecular thing. And then breast cancer, HER2/neu, if you can see, HER2/neu amplification, if you detect by FISH, it is going to respond to trastuzumab, which is a monoclonal antibody. So targeted therapy is the most important implication for molecular methods now. Okay. So targeted tailored therapy is there. Then tumor markers. So tumor markers are nothing but these are actually derived from the tumor cells only, and they are circulating in the body fluids. So anywhere, it can be detected in any of the body fluids, be it saliva, serum, urine, or even from the tissue fluids, so blood, anything you can see. So these are the tumor markers, and as such they can, if it is present, you can tell that there is a tumor, indicative of tumor, but as such it is not a confirmatory test. So wherein this tumor markers help? Only when you had given a treatment. So once the treatment is given, the tumor markers has to come down, because the tumor cells are going to become less, right? So tumor markers will also come down. So if the tumor markers are still above, it can predict the tumor response to the treatment. So to assess the response to the treatment, you can use this tumor markers. Serial wise assessments, they'll be doing it, serial assessments of the tumor markers. And apart from that, you can also detect the tumor recurrence. So initially post surgery, the tumor markers must have come low, very low, and then suddenly after during follow up, they detect this increase in the tumor markers. It suggests there is a recurrence. So for these two conditions, tumor markers are useful. So this again is going to be an important table here. So what are the tumor markers? So under hormones, we have calcitonin. You can check for serum calcitonin levels, which are going to be elevated in medullary carcinoma of thyroid. Beta HCG, we all know it is for choriocarcinoma. 5-hydroxy-indole acetic acid is for pheochromocytoma and for carcinoid also. Vanillyl mandelic acid in the urine, you can study this, and this is again for pheochromocytoma. Then oncofetal proteins. So normally these oncofetal proteins are expressed during the fetal life only. So during tumorigenesis, these are again going to be expressed. So alpha fetoprotein, it is expressed by yolk sac tumor. So this was again used as a serum marker also, right? So here if we see immunohistochemistry also we had used it, and it's also a tumor marker. Alpha fetoprotein. It is also seen in hepatocellular carcinoma and hepatoblastoma. Hepatoblastoma is going to be seen in kids, while hepatocellular carcinoma seen in adults and kids. CEA, carcinoembryonic antigen. Okay, so this is going to be expressed in lung cancers, pancreatic cancers, stomach and colon cancers. Okay. Then under enzymes and proteins, we have prostate specific antigen. So as the name suggests, it is for prostate cancer. Then PAP is prostate acid phosphatase, again for prostate cancer. Then NSE is neuron specific enolase. So neuron is there. So obviously it is for neuroendocrine cancers, neuroendocrine tumors. Immunoglobulin is for multiple myeloma. LDH is for seminoma usually. Seminoma or dysgenoma. LDH is lactate dehydrogenase. Glycoproteins, CA125, it is going to be elevated in ovarian epithelial tumors, especially the serous carcinoma of the ovary. Then CA199 for pancreatic cancers. CA153 is for breast cancer. CA72-4 is for gastric, ovarian and pancreatic cancers. CA2729, it is for breast cancers. Okay, so this entire table is again important. Then the last one, this is the newer one addition in the Robbins. So cell-free DNAs, I already mentioned, right? So cell-free DNAs you can identify for specific mutations. So that is the DNA, right? So you get the DNA of the tumor cells. So from that you can directly identify the mutations. So in the serum, if you check for the EGFR mutation, it is going to be for lung adenocarcinoma. Remember, EGFR I told it is going to be targeted therapies there, erlotinib and geftinib. So for that reason, you can check the serum EGFR mutants. And in the serum and stool, you can test for TP53, APC and RAS mutants. So APC, if you see, it is going to be for colon cancer. Urine TP53 mutation, so urine is there, so obviously it is going to be for bladder cancer. Then serum and sputum, so sputum is there, you can test for TP53 and RAS mutants, so sputum usually for lung cancer. Out of this EGFR and this colon cancer is going to be very important. So these are the methods for diagnosing the tumors. So we have multiple one-liners here. It is easy to memorize it and then you can score it easily. So finally, we'll see about the various chromosome numbers. So we had seen about n number of genes and their chromosome numbers here and there, right? So I've tried to collect it and put it in a order. So they are asking for the chromosome numbers also. These are also again direct one-liners. So chromosome 2p is going to be associated with the ALK gene. So where all did we see ALK gene? ALK gene was for lung adenocarcinoma, one thing. Then ALCL was there, right? And also for neuroblastoma. Okay. Chromosome 3p for VHL gene associated with clear cell carcinoma of the kidney, and then cerebellar hemangioblastoma and retinal angioma. Then chromosome 4 was Huntington gene present, which is mutated in the trinucleotide repeat mutation seen in Huntington's chorea, and chromosome 4 is also involved in adult autosomal dominant PCKD, polycystic kidney disease. So both chromosome 16 and 4 are being involved in the ADPKD. Okay. So chromosome 5 for FAP, familial adenomatous polyposis. So APC gene was there, right? So APC is the gene and the FAP is the syndrome. Cri-du-Chat syndrome, so cry like cat, I told, right? So that was partial deletion of chromosome 5p. Then chromosome 6, HLA gene was important, HLA gene. Then you also have a HFE gene which is seen in hemochromatosis. So one of the genes mutated in hemochromatosis is HFE gene which is present on chromosome 6p again. Then autosomal recessive polycystic kidney disease is the gene is going to be PKHD. So autosomal dominant, the genes are PKD1 and 2. This is present on chromosome 16 and 4. While autosomal recessive polycystic kidney disease, it is PKHD gene which is present on chromosome 6. Then chromosome 7 is for cystic fibrosis, which is CFTR gene. Then chromosome 9 we have ABO blood group, and RH blood group was in chromosome 1. Remember, RH for chromosome 1, ABO for chromosome 9, and HLA is for chromosome 6. So other than that, we also have CDKN2A, which is P16. P16 we studied in cell cycle, right? So CDKN2A, it is going to be mutated in glioblastomas and also in melanomas, present on chromosome 9. So chromosome 10, n number of times I had already repeated. So then Cowden syndrome and P10 mutation. Okay, apart from that, MEN2 syndrome, red gene is also going to be present. So Hirschsprung's disease also is involving the red gene only. Then we have chromosome 11. So chromosome 10 is MEN2, while chromosome 11 is going to be MEN1, which is the menin gene. So MEN1 is for MEN1 syndrome, right? And then we have ataxia telangiectasia gene, ATM gene. Then Wilms tumor, both the Wilms tumor genes, WT1 and T2 is going to be present on chromosome 11 only. This is going to be chromosome 11, 13, and this is going to be 15. Chromosome 11, 11p13 and 11p15. Okay. Then the beta chain of hemoglobin. So hemoglobin, we have two chains, alpha chain and beta chain. Alpha chain is on chromosome 16. Beta chain is present on chromosome 11. Then in chromosome 13, we are going to have retinoblastoma gene. So RB gene is chromosome 13q14. Then BRCA2. So BRCA1 is going to be present on chromosome 17, while BRCA2 is going to be present on chromosome 13. Then we had trisomy 13, which is Pathology syndrome. Then Wilson's disease, the gene ATP7B is again present on chromosome 13. Then chromosome 15, the gene fibrillin was present. It is mutated in Marfan syndrome. Prader-Willi and Angelman syndrome, again genomic imprinting, right? Genomic imprinting. So these again were involving the chromosome 15. So in chromosome 16, I already mentioned alpha chain of hemoglobin. Then adult autosomal dominant polycystic kidney disease. Then chromosome 17, very, very important, TP53, which is 17p. Chromosome 17p is TP53. Then BRCA1. BRCA2 was in chromosome 13. Then NF1 is also present in chromosome 17. So NF1 and 2 is going to be present on chromosome 17 and chromosome 22q. Okay. NF is for 17 and 22. BRCA is for this. BRCA here will be 17 and 13. Okay. Chromosome 18 is Edwards syndrome, trisomy 18. Chromosome 19, myotonic dystrophy, which was a trinucleotide repeat, CTG repeats, which was present in the chromosome 19. Chromosome 21, Down syndrome, obviously, trisomy 21. Then Down syndrome, we saw APP gene, right? Amyloid precursor protein. So Alzheimer's is again amyloidosis precursor protein. So all of these three are related with the chromosome 21. Chromosome 22, again NF2. So NF2 was associated with two cancers mainly, right? Meningioma and schwannoma. And another thing is DiGeorge syndrome, in which we are going to see 22 deletion. DiGeorge syndrome was the one we saw catch-22 mnemonic, right? Then chromosome X, you can write all the X-linked disorders we had studied in genetics. So Fragile X syndrome, Lesch-Nyhan, S-linked SCID, X-linked chronic granulomatous disease, hemophilia, G6PDs, Hunter disease. So all of these are going to be examples of chromosome. All of these genes are going to be present in chromosome X. So this you can use it finally for revising.